Now, Guenter Breithardt and Dr. John Cleland, professor of cardiology at the Castle Hill Hospital in Hull in the United Kingdom, discuss telemonitoring, a valid tool for patients with heart failure.
Welcome, John.
Thank you for the invitation.
What is telemonitoring?
Telemonitoring is a whole system of care. And I think you need to think about this as an electronic patient record, which allows you to store and retrieve information and information processing, and then provide decision support tools both for patients and for the healthcare professional to make sure that they don't forget what they're supposed to do and also what they're supposed to act on. So it really helps a lot more people become really expert in terms of managing care. That's the background, as it were. Then you need the communication tool and system between the healthcare professional and the patient, or the system and the patient, because I think in the future a lot of the advice is going to be directly the system with the patient. We've already seen it with some of the implantable devices. There's a great study called Laptop where there's a left atrial implanted device, measures left atrial pressure, and then that's connected to a PDA, and the PDA advises the patient how much diuretic to take. So this takes the doctor and the nurse out of the loop and puts the patient and the system in direct contact and getting the patient much more as a participant and as a caregiver. And we should remember that patients are the largest available healthcare workforce that we have. And we shouldn't neglect them.
So that means interactive, both on the level, let's say, of the caregiver, of the doctors, the nurses, but also on the level of the patient. So the patient can adjust his medication based on the information provided.
Absolutely. And of course, the nurse and the doctor are still there to provide expert care to make sure that the system is not going wild and out of control, because we're going to need that for some time to come. I think that these systems will become more intelligent as they get more experienced, and the relationship between the health professional and the system will change over generations. We should remember that when you train an expert doctor or a nurse, well, he may train more doctors and nurses, but he's got a finite lifetime and he's going to retire, and you're going to lose all that expertise. With these systems, they're going to go on learning forever. So they're going to become more expert over time. To turn to the communications aspect of it, the communications are there to provide educational tools and messages to the patient. They're instructions from the system, the nurse and the doctor, and they're also to make sure that what the doctor and the nurse think the patient is taking in terms of medication, that the patient actually agrees and says, yes, this is what I'm taking, because medication errors are a big problem in terms of patient readmission and I'm sure some other unfortunate outcomes.
Taking the term telemonitoring, it suggests that the patient is at some distance. Does it mean it's only something which we should consider for the patient who is in a remote area with difficult access to the healthcare system? Or is there a definition of how far the patient should be?
Well, there's no real definition, and the patient may be as close as the bed across the other side of the ward. But from the purposes of home telemonitoring, obviously, we are talking about a non-hospital domicile. Should be said that, one of the big places where we see telemonitoring taking off is in residential care homes for older people. And very often that's one system with multiple users rather than one system per user. These systems are flexible and they should be flexible. It's not a one-size-fits-all system and everybody should have the same. There'll be different niches for different approaches. In terms of the patient, of course, the patient's engaged, and I think the systems that we're generally working with at the moment give you a minimum of a blood pressure, a heart rate, hopefully heart rhythm as well, and weight. And with this on top of the symptoms, the knowledge of the background disease that your patient has, together with their medications, I think provides the opportunity for higher quality care. The objective of telemonitoring has really shifted over the last 5 years from one of trying to detect impending deterioration and a crisis in the patient to one of an approach I would call health maintenance. And the idea here is not to wait for bad things to happen and then respond to them, but try to optimize treatment right from the outset. And the idea is to keep the patient in the best possible situation. And I think when you do that, you're much more likely to modify the natural history of the disease rather than waiting for things to go bad and then trying to fix them.
In how far does the patient have to interact with the system, not only responding to some recommendations, but providing the data? ECG can be maybe recorded through a pacemaker, but many patients will not have a pacemaker, especially talking about the heart failure population. So does the patient have to provide some of the data? Does the patient have to take the blood pressure himself or herself? How does that work technically?
Yeah, well, with the systems we've got at the moment, there is the need for patient engagement, and that may be a good thing and may be an advantage of the systems, that the patient is more aware of their illness, more in control of their illness, and feeling that it's something that they can contribute to their own care. For other patients, of course, it's just a bind and they don't want to do it. We can certainly say that probably between 10 and 20% of patients really don't like telemonitoring systems and they don't like the technology. I would say 80% see it as a guardian angel and actually
I've seen
really like it.
Are very happy to have these systems.
Some very happy and some not at all happy. And of course, doctors have their prejudice and listen to one group of patients and not the other. They should have a balance and realize that this is a great solution for some patients and some patients hate it. Implanted systems, of course, and there are some nice little subcutaneous devices now, and the patient can just forget about it. And at least in terms of heart rate and rhythm monitoring, blood pressure, of course, is a bit more of a problem. We have to just say at this point that many of these patients are elderly, and people say, how can they cope with the technology? But remember, in residential accommodation, there's a warden who can help. Very often these will have helpful neighbours, sons and daughters who can come and help. And again, you're recruiting extra people to the healthcare workforce who can provide information which is not expensive to obtain.
So presently we seem to be very optimistic, but what is the evidence that it really provides an advantage, let's say a better quality of life for the patient? That would be already important, but maybe even prolong life if we talk about this population with heart failure.
Well, we've got two strong pieces of evidence in favour of telemonitoring, and we've got some studies that have weakened that position. So it's good to, again, talk about the balance and not just go to one extreme or the other. There's been a Cochrane systematic review of trials that were completed up till around about 2010, and that suggested that there was a reduction in overall mortality with telemonitoring, a substantial reduction, around about 36%, and also a smaller reduction in hospitalisation. Very recently, publication in the British Medical Journal, the Whole System Demonstrator, a study of over 3,000 patients, and again showing a reduction in all-cause mortality, highly statistically significant, around about a 40% reduction in mortality, which is substantial.
I assume on the basis of standard therapy.
Well, that's a very good point, and we'll come to that good point in a moment. This was general practitioners looking after people with or without the system. And when the general practitioner was supported in delivering care through the system, we saw this big reduction in mortality and a reduction in emergency room visits and hospitalizations.
But did they also get better medication?
I'm sure they got better medication. Suddenly, by taking people's blood pressure, you don't save lives or stop hospitalizations. It's what you do as a consequence of the information that changes outcomes. So there must have been changes in management that led to these changes in mortality. It was a large German study, very well conducted German study called TIMHF, which failed to show a difference. The reason I think it failed to show a difference was the expert care that the control group received. So I think that you can do as well with telemonitoring just by conventional care if you have enough of it and you have enough high quality conventional care. But if you don't have that high quality conventional care, telemonitoring may be an excellent system for improving your care to the highest standards.
What about reimbursement? It might be very difficult on the various healthcare systems.
Very different in the different healthcare systems. I don't think there'll be a one-size-fits-all. I think there'll be different services will need different approaches. Some will like to purchase their equipment and provide the service all by themselves. Other people will want to buy the service and leave it to others. Yeah. Personally, I think it's the local doctors and nurses providing part of their care through telemonitoring, for me, is the best system. I'm not quite sure that having a national telemonitoring centre in 24/7 is the best way to go. I think that might be expensive, and I think it might depersonalise care. The thing is to get the systems to make the local people real experts in delivering care.
Okay, thank you very much, Ron. I think this is very important information. I'm just thinking about when telemonitoring might have started, maybe with the first man in space, where there was a need to transmit the ECG without a cable. And so maybe we are fascinated since then, and it's an evolving area. Thank you very much for joining us here.
Thank you.